Hello everyone, Assalamu alaikum wa rahmatullah. Now this is a quick session regarding the vesico-vaginal fistula. It's a very important station in the exam, guys, because it's highly repeated station. It's a structured discussion, and we have to cover well in the exam. And it's like a very easy station to get in it the full mark. And as I told you, it's a highly repeated station, so we need to cover in a good way. So now, usually the scenario will be like you are the ST5 in the emergency department and you have been called to see a patient. Usually this patient will have fluid loss or loss of urinary control over the last 3 weeks or starting 3 weeks after the abdominal hysterectomy. Now you will meet the examiner and the examiner will ask you questions. Usually the first question will be the differential diagnosis and then information gathering point, relevant history, what do you want to ask, and also examination, investigations, and then the management plan. So it's a differential diagnosis case because we have a lot of causes may lead to fluid loss after surgery. Usually you will be assessed in the following domains: applied clinical knowledge, information gathering, patient safety, and communication with the colleagues. For the introduction, as usual in any structured discussion, so you have to say, hello, for example, tell your name. I'm Rana, one of the exam candidates. I've read the instructions and I'm ready for the structured discussion. First question will be the differential diagnosis. So the differential diagnosis, we have 6 differential diagnoses. Fistula, 3 types of fistula here, guys: vesico-vaginal fistula, ureterovaginal fistula, and rarely to be urethrovaginal fistula. So we have to mention the 3 types. It may be urinary tract infection, may be stress urinary incontinence. Sometimes the symptoms of the stress urinary incontinence start to appear after the hysterectomy. So, or the patient has like mild symptoms before and now it's more significant. Vault hematoma and pelvic collection or retention with overflow. So we have 6 differential diagnoses here. Information gathering. What about the relevant history here? We will go with the template. We have to usually to ask the patient open questions. So you have to tell the examiner, I will start to ask patient questions regarding the current condition. So we will start with the history of the present illness. I will ask her to tell me more about this problem. And for the incontinence or the fluid loss itself, since when it started, what about the color? What about the odor? Is it bloody or not? Is there any pain in the pelvis, pelvic pain or abdominal pain? Is there any fever? What about the recovery after the hysterectomy? I will ask her about the surgery. If she knows anything about the surgery, was it a straightforward surgery or she had any problems during the surgery? If not, after permission from the patient, I can check the notes to know if the patient had any complications, intraoperative or post-operative. So all of these is the history of the present illness. Then we will continue as usual, guys, with the template. So personal history, I want to know about the smoking, if this patient is a smoker or not, alcohol intake, what about the recreational drugs? I want to know about her BMI. For the patient safety points, usually we need to check if this patient is allergic to any medication, and also if the patient has any concerns regarding blood transfusion, we need to rule out the Jehovah's Witness, because now this patient, we may need to take her back to theater after a while. So we need to check this point. And what about cervical screening? It's not important here because already the patient had hysterectomy. We can ask her about what about just before hysterectomy? Was it up to date and normal or not? We need also, regarding the hysterectomy, guys, to ask about what about the reason of this or the cause of the hysterectomy? Was it a malignant cause or a benign cause? So it's very important. Obstetric here important because we want to know the mode of delivery. If the previous deliveries were by cesarean section, so if we will go for a repair, it's a fistula. And if we will go for the repair of this fistula through the abdominal route, so we will suspect more adhesions and also especially after the hysterectomy. Menstrual contraception here, not important. Gynecology, we can ask her regarding if there is any discharge or something like that, just to exclude any infection. For the medical history, very important to rule out any chronic disease. So some kinds of the disease like diabetes, this will lead to poor healing and it will affect the general health of the patient. So we need to check if the patient has any chronic condition, any surgeries in the past, for the same reason like the obstetric, just to check if we will suspect more adhesions during the surgery. What about the family history? Is there any family history of concern, especially for the VTE? Because this patient, she will be admitted again to the hospital. We may take her to the theater, so we need to assess her regarding the VTE risk, and by the end, we will offer her a low molecular weight heparin. Mental health here, guys, very important. And actually, usually I'm keeping the mental health with the red color. It's very important in most of the modules. So my advice, usually keep it in all modules, because now this patient with a major surgery and now with a major complication, and this major complication will need hospital admission, and we may take the patient back to theater. So her mental health for sure will be affected. So now we need to check what about her mental health, if it's compromised, so we can involve a counselor or a psychologist in her management, just to help her how to cope with her condition. Social history, very important. What about support at home? Because also this patient will need a prolonged recovery. And if we will take her back to theater and surgery will be done, so she will need support at home. Even with the conservative management, with the catheter, she will need support at home. So we need to check this point also in the information gathering. Coming to the examination and investigations, I make it like mixed here together. We need to have like general examination of the patient to check her vital signs as well, blood pressure, pulse, temperature, and what about her respiratory rate. We need to do vaginal examination just to check we can see the incontinence or the fluid coming by our eyes, or to check if there is any vault hematoma so we can see. We can offer this patient a high vaginal swab to exclude any infection, and to offer her urine analysis to exclude the UTI, urinary tract infection. And we have some general investigations like liver function test, kidney function test, and full blood count. For the fistula itself, or to diagnose the fistula, so we have 3 gauze methylene blue test. How are we gonna do it? Usually it's not recommended. We can diagnose with the retrograde cystography, but how are we gonna do the 3 gauze methylene blue test? We will put 3 gauze inside the vagina, 1 at the upper part, 1 middle, 1 lower. And then to inject methylene blue through a catheter in the bladder. And then we will ask the patient to walk for 30 minutes and to come back to us. Sorry for this interruption. So let's continue. I will put the 3 gauze inside the vagina. As I told you, 1 upper, 1 middle, 1 lower. And then I will inject methylene blue here with a catheter inside the bladder. And then I will ask the patient to walk for 30 minutes and then to come back. Then we will take out this gauze and to check which one is colored with blue. If it's the upper one, so it's upper fistula or high fistula. So if it's the middle, it's middle fistula. If it's the lower, so it's a lower fistula with the bladder vesico-vaginal or urethro-vaginal. Retrograde cystography, with the same technique, I will inject the dye and then we will take like the X-ray and we will check for the site and the size of the fistula. Cystoscopy, using the cystoscopy, so it will be under eyes, so we can see the fistula itself, and we can assess also the size. IV pyelography, if I suspect ureterovaginal. So if the problem with the ureters, so it's better to have IV pyelography. So these are the examination and all the investigations. Vaginal examination, general examination, vital signs, swab, vaginal swab, urine analysis, liver function test, kidney function test, full blood count, 3-gauze methylene blue. So here, this is a diagnosis of the fistula. Retrograde cystography, cystoscopy, or IV pyelography. What about the next step? The management. So now the examiner will tell you, you diagnose vesico-vaginal fistula. How are you going to manage this case? So for the management, generally, it will be according to the cause. And as I told you, now the examiner will tell you it's vesico-vaginal. So first of all, this patient has to be managed with a multidisciplinary team. This will include my consultant or the consultant gynecology, urologist, hematologist, anesthetist, counselor, and a specialized nurse. If the size of the fistula small, which is less than 5 millimeter, and please guys, because I noted that most of you, they didn't mention the size of the fistula. So the management will be conservative. If it's a large fistula, more than 5 millimeter, so this fistula needs a repair. So the small fistula first, conservative. How are we going to do the conservative? Catheter under coverage of antibiotic. So the catheter will be for 6 to 8 weeks, take care of the timing, and may be extended up to 12 weeks, 3 months. So take care of that. We will give the patient antibiotic not for the whole period, not for the 3 months, so antibiotic for 5 to 7 days, but for sure, if this patient will come for follow-up and you notice that we may have a UTI, yeah, you can prescribe again antibiotics. Do we need here a follow-up for this patient? Yes, and follow-up has to be after the time. So after 2 months, we will check the patient. We will offer her retrograde cystography. If we can find that the fistula is completely healed and we don't have any problem, so we can remove the catheter and we can discharge the patient. If the fistula still not healed, so we can extend the timing up to 12 weeks and then do the test again. If not healed, so we will manage like the large fistula with a repair. If healed, that's okay, and discharge the patient. Don't forget to teach the patient about the catheter care before going home. Don't forget to give her the red flag signs, like if she has any pain, any burning sensation, any blood in the urine bag, any change in the color of the urine, any reduced amount of urine in the bag itself. So she has to come immediately to the emergency department and to give her 24/7 contact number. So this is the catheter care. For the large fistula, now we need a repair. The examiner's question will be when you will get this patient back to theater for a repair. So we have 2 types of answers, or you can answer in 2 ways. Either to say, I will wait until the edema subside and then I will take the patient back to theater, or to give the exact time, which will be 3 months or 12 weeks. So the healing, not the healing, just the tissues will not be edematous, and this edema will subside and then take the patient back to theater. How you gonna repair? First of all, I will dissect the fistula, because usually after a time, the fistula will have a hole and there is epithelium on the fistula wall. So we need to dissect this tissue. And now we will have the bladder and the vagina. The bladder has to be sutured in 1 or 2 layers. It's not important to be 2, but you have to choose whatever you are comfortable with, 1 or 2 layers. We will use 2-0 Vicryl. This is the best one for the fistula or the bladder repair. We have to repair the bladder with running and non-locked repair. The distance between the stitches or the sutures has to be 0.5 to 1 centimeter apart from one to another, and also the same distance, 0.5 centimeter to 1 from the cystotomy angles. If we have any injury to the trigone, it has to be to be done with additional attention, and for sure it will be the work of the urologist. We have to avoid obstruction of the ureter or the ureters, two ureters, and for the urethra. Ideally, for the sutures of the bladder to be watertight, tension-free. Please, it's like a buzzword here for the repair of the bladder. So take care of that. Watertight, tension-free. And after the repair, we can just check the suture line with a methylene blue dye intraoperative, just to check that the repair is done in a very good way. Then we will insert a bladder catheter for 2 weeks under coverage of antibiotic for sure. So don't forget the timing for the conservative, 6 to 8 weeks up to 12. Here with the repair, it will be 2 weeks. After the healing, this patient will need follow-up or not. If during the repair, you feel like it's a straightforward repair and straightforward surgery, so no need for follow-up, because even intraoperative, you already check the suture line. If the surgery itself wasn't straightforward or you face a problem during the repair, so at this time, offer this patient retrograde cystography as well. Don't forget that we have 3 routes here, either to be done vaginally or to be done abdominal or with the laparoscopy. We can also use the fat pad or the omental pad in between the bladder and the vagina after the repair. So if it will be done vaginally, so we can take the fat pad from the labia, or intra-abdominal, so we'll take part of the omentum and put it between the urinary bladder and the vagina. What about the clinical governance issue? Before the clinical governance, please don't forget in the management, whatever you will do, conservative or large, or repair large fistula, we need to assess the patient for VTE, as I told you in the information gathering. And here the hematologist will check what about the suitable dose for her for the low molecular weight heparin. Very important, because this patient will be admitted again. And even with the conservative, she will have like limited mobility with the catheter. So we need to give her low molecular weight heparin, and especially for sure for the large, if she will be admitted and the repair will be done, she will stay in the hospital for 2 to 3 days, and the recovery will be 4 to 6 weeks. So for sure, we need low molecular weight heparin, one of the patient's safety points, so please don't forget it. For the clinical governance issues or points, I need to declare what happened to the patient, to be honest with the patient. I have to do the duty of candor. I have to apologize about what happened to her. And I need to initiate incident report, involve the risk management team to know what about the cause behind that. And if it's a frequently repeated problem, so we need to do an audit for that. We need to do skill and drill in the department. So we have to do reflective practice on this case, and also to check if the electrosurgery, because it's the most common cause here for the late onset fistula, if the fistula appeared just immediately after the surgery, so it will be injury. But if it's late onset, usually it's thermal injury, because the thermal injury, it will take 2 to 3 weeks to appear. So now, how to reduce this? To learn more or to know more about the electrosurgery, to know more about the safe use of electrosurgery, and to avoid unwise use of the electrosurgery, because some of the surgeons will use the electrosurgery from the first minute of the surgery till the last minute. So we need to avoid the unwise use, because usually you will not see the injury by your eyes during the surgery intraoperative, and it will appear after the surgery. So it's now done for the vesico-vaginal fistula. I wish this quick session will be of benefit for all of you guys. Thank you so much.